Before I introduce our distinguished panelists, what I'm going to do, because I know some of you probably you're not following the evolution and unfolding of the global health program at Western Connecticut HealthNet, as well as University of Vermont, I thought really I'm going to just show you a few slides and debrief you and up-to-date you on where we are in global health. This is a village in south and west of Uganda, very famous or infamous because gave birth to HIV in central and the east part of Africa in early 1980s. And the name of this town or this village is Kazenzro, and surprisingly still in 2015, almost 50% of 10,000 population of this village, and they have HIV. And this is a question that I ask selected number of the best students in one of the high school of this community. And my question was basically, who is orphan? And you would see almost 95% of the hands went up because they lost basically one or two parents to the HIV epidemic during 1980s and 1990. And the question that really all the time I had was basically who is going to tackle this sort of really humongous challenges. Obviously, from my perspective, is going to be young medical students because they are talented, they have phenomenal really motivation, and they want to be the leaders of the world. So to put together a curriculum or a program around global health, basically, I thought really we have one of our major objectives of global health is giving the opportunity to those that they have potentials to become the citizens of the world. Discover them, nurture them, and let them become the leaders of the global health. And hopefully in future, we are not going to have communities like Kazenzro with 7,000, 10,000 population, 2,000 infants, and 50% of them suffering from HIV. The principles of a good global health program is all crystallized in this slide. Is based on the partnership. You need to have phenomenal, great partners in few countries around the world. It should be, the benefits should be bi-directional, basically, and it should be based on principle of immersion. Immersion in the culture, immersion in basically clinical care. And it's not just going for seeing another landscape. Obviously, it should be under supervision based on LCME guidelines or ACGME guidelines. And obviously, research and scholarly activity has to be a part of this initiative. And there is no question that the safety of the participants has to be discussed constantly, and it should be really priority in any good and productive global health program. The program that you have in this university is multidisciplinary. We have 3 partners, is obviously Western Connecticut HealthNet, and by that I mean Danbury, New Milford, and recently really Norwalk. And we're blessed by having substantial number of really amazing global health specialists in Norwalk, and one of them is one of the member of the panel tonight. And obviously, we do have also partner with Sacred Heart University because we need really to have a partner in nursing school. And obviously, it is very multidisciplinary from pathology, nursing, psychiatry, emergency medicine, intensive care unit, cardiology, oncology, OB-gynecology, pediatric surgery, and medicine. The group are going to be selected far in advance before being sent to any of these fields, and they go through very vigorous weekly orientation, and particularly during this weekly orientation, We teach them how they should avoid basically any sort of really unsafe or high risk basically behavior in these countries. There are classes, there are evening sessions like this afternoon, and many of the classes basically or the topics already have been published and they are also available distantly. We have 5 sites, historically, chronologically, Russia, because we established a site in 1993, then Uganda, 2002, and Vietnam, Zimbabwe, and Dominican Republic. They are all happened in the last really 3 years. Just showing you a couple of slides, a couple of your students basically in University of Zimbabwe, and they were members of the exchange microscope, so they were basically taking fantastic, really, multi-head microscope and give as a gift to the Department of Anatomy in University of Zimbabwe. Here is Dr. Lan. She's coming from Vietnam, and any site that we establish a new program, we select somebody from that site to come to the United States to be trained for 5 to 12 months, to be completely familiar with LCME standards, ACGME standards, basically medical education in the United States. And then when that person gets back to that country, is the site director of us and is the contact person. And here you can see one of your senior medical students last year was in Vietnam with Dr. Lan. And Dr. Lan also is a cardiologist, and she was trained mainly in echocardiography when she spent, I think, really 6 months in Danbury. This is Jomar Florence, and she's our site director in Dominican Republic, and with Liliana, the head of the hospital. And Jomar also spent 6 months in the United States to be completely familiar with our expectation before we send any medical students to Dominican Republic. And finally, in Dominican Republic, I was looking really for a good partner because, your partner in any sort of really, collaboration should have significant potential for bi-directional, mutually rewarding type of the projects. And here, finally, we identified really a group, one of the medical schools in Dominican Republic. This is the only medical school that the language is English, and they are so basically interested. In a matter of fact, they knew Dr. Bill Jeffrey from his book, and they really want to come and learn about the medical education and curriculum or new curriculum development. And I would bet this collaboration between particularly Department of Medical Education of your university and UNEP University in Dominican Republic is going to be very, very productive. And also in Dominican Republic, the place that we send medical students has 28,000 population. 10% of them are Haitians, and the rest are Dominican Republic. And the spirituality, the practice of the religion in this part is completely basically deep. And we are recruiting one of the anthropologists and artists that, in a matter of fact, spent 20 years studying the impact of spirituality and religion in clinical manifestation of the diseases. And he's going to supervise basically a couple of medical students in Dominican Republic in a couple of research projects about the cultural sensitivity and how the culture background would show itself, in a matter of fact, in clinical manifestation of the diseases. Russia is the Kazan, and later on I'm going to really basically, panelists are going to talk more about really this site that we have, a beautiful really part of the central Russia. And you remember Professor Sovan, and this is Professor Zinganshin, who is one of our panelists this afternoon. And we have the tripartite type of the partnership with Uganda, Russia, and University of Vermont. And later on, I can really speak more about this tri-partnership and why really we are developing this kind of really model. But here you can see a group of the medical students from Russia have been selected to go to Uganda. And obviously, they have been also to United States. So they got some training in Uganda, then they come to United States, and then they get back to Russia. And all of those alumni, they are the supervisor of the medical education of the students and the residents that we are deploying to those countries. And obviously, it is the international office of the Makerere University College of Health Sciences, the Oxford University of the Africa, and tonight we have, in a matter of fact, the Professor Oboa, the Vice Chancellor of the second biggest university in Uganda, Mbarara University, who used to be, in a matter of fact, the head of the international office for a long period of time, and Susan, the international basically coordinator, and she completely really revolutionized the concept and philosophy of the global health in the department of the international. Here, obviously, you know Tamar very well, and you know that a couple of really senior members of the Makerere University have been guests of this university, and Fiona, a young pathologist that has spent 1 year, in a matter of fact, at Danbury Hospital, and just recently got back to Uganda, and she is going to be our key person in the Department of Pathology in Uganda. Obviously, you will see that when faculty and residents and the students, they go to any of these countries, they go for house calls. It's not only just clinical work in the hospital. They will go to the homes to see the culture of the people in host countries. And I know that sometimes it's emotionally it's very draining, and they need some counseling, and they live with family, and during the dinner time, they learn the language, they learn the social aspect of the medicine, political aspect of medicine, cultural aspect of the medicine, and any of them has really some sort of really question, observation that is going to be very hard to be digested. That the story comes up, and the leader of the group tried really to walk through the person through the daily observation. This is the dinner time, and you probably recognize a few of your friends among the participants. We also very much engaged in research. This is one of the towns in Uganda that 98% of the population, they have schisto, and we are doing, in a matter of fact, a study on predictors of the upper GI bleed among the community that they have schisto. And we do research with the communities, and this is one of our pre-med students that is, has a project with the community to know exactly really, what is the needs of the community when you come to healthcare delivery. I told you about Kizenzero, and this is one of the big groups that, in a matter of fact, we sent to that village basically for woman health issues, and they did vaginal exam, cervical swab, and for a week they lived in that village, and they provide service to that community. I would really stop here, and then I would request really the panel to come and take seats, and then I do have only a few questions for them. Please, Professor Ziganshin, Oboa, and Susan, please. I would bet Susan have never seen a snow, and this is probably the first experience. Though I told her that don't blame us. You're coming from Uganda, and you're very close to Kilimanjaro. You brought some snow from the top of Kilimanjaro to Vermont. And you know, they had a very long flight from, obviously, you know, Uganda to United States, and then short, brief rest, and then 5 hours of really driving in the snow, obviously, and just got here this afternoon, in a matter of fact. I'm very thankful really to all of you, and particularly, I know that some of you also have a very big practice. Patricia has, infectious disease, HIV. But my first question is really requesting each of you very briefly in 25 seconds. Only tell who are you, but don't focus at all on global health. Give you basically your title, from where you're coming, and what you're doing. Susan. Yeah. Yeah.
I am Susan Osaka Yokwaso. I work as an international officer at the College of Health Sciences, Makerere University. I organize international health placements for students across the world. I work with over 285 students per year, and my role is to ensure that their objectives are met while they are visiting the country. So if you tell me you want women and health, I make sure I put you in a place where you will be able to learn about women and health. Yeah, nice to meet you all.
Professor OBrien.
Good afternoon, ladies and gentlemen. First of all, I'm grateful for the warm reception that I've got at Vermont. It's warmer than I expected. And so my name is Celestino Bua. I'm a medical doctor and a pharmacologist with eventual training. I got a PhD in pharmacology from Karolinska Institute in Sweden, Stockholm. And after that, I came back, joined the College of Health Sciences as first, of course, teaching in a department. Later on, I got administrative position as the deputy principal of the College of Health Sciences. That's what brought me into international collaborations, because the mandate of deputy principal in Makerere is that you're responsible for partnerships, collaborations, research, and everything. However, about 5 months ago, I left Makerere and went to the second oldest. Now, when we say second oldest, it's not that old. It's 25 years old. Public university, which is a bit southwest of where Makerere is, some 260 kilometers out of Kampala, Mbarara University of Science and Technology. Smaller student community compared to what is at Makerere. And so I'm settling in at Mbarara, but as Dr. Majid said, just before I moved, that picture you saw, I was actually on my way out, and I told him that, well, since we have done very well at Makerere, why don't we also move this relationship to Mbarara University, which is closer to the Millennium Village. So I think that's the reason I'm here. I'm trying to woo you into coming to Mbarara. Thank you.
Good afternoon, everybody. My name is Ayrat Ziganshin, and I came from Kazan, Russia. I graduated from Kazan Medical University, and then I did my PhD in pharmacology there. And then I went to London for 4 years. I was a research fellow in University College London. Then came back to my hometown. And then from that on, I've been involved in international relationship of our university, been in administrative work. Currently, I'm a head of department of pharmacology in our university, and I'm still very interested in global health and international relationship. And this mostly due to Dr. Sadiq Majid, of course, because we've been not only good partners, but good friends, I think. And now it's family business. Thank you.
And Patricia?
Hello, everyone. I'm Pat Wetherell. I'm an infectious disease specialist. I'm originally from University of Missouri in Columbia, so I'm a Midwesterner. And then I went to Yale and stayed at Yale for a long time, did quite a bit of clinical research in HIV initially. And then I branched out. I left the quaint Yale community and went to the Pacific Rim. So I lived and trained and taught and educated many around the Melbourne area. And did mostly HIV there, but also quite a bit of travel medicine. And then came back for a bit and then moved to Singapore and lived in Singapore for a long time and taught and trained in Singapore. And yeah, worked on all of the ID docs, helped train up the fellows and do everything academic at one of the teaching centers there. And now I'm back and I'm at Norwalk. And I do a lot of the training with the medical students and the residents. I do a lot of the board review and all of the various ID-related issues at the hospital. Thank you.
I would ask Pat particularly this question. When they invited me to Norwalk, I saw suddenly really many of the residents so engaged in global health, and so many of the faculty very much engaged in global health. I want to tell you during this summer, we are going to have 8 of the first-year medical students in 4 corners of the world. But for the first time, not only we have the alumni locally that we are going to support the medical education of this group, but each of this group is going to go with 1 medical resident from Norwalk and is going to be supervised by 1 of the faculty constantly. On the other hand, imagine that from Norwalk alone, 9 faculty, they volunteer themselves each for 2 weeks, basically to cover and supervise the medical education of the resident that who is going to stay for 6 weeks and medical student who is going to stay for 6 weeks. I want just to learn that secret. I'd love really to know what happened really in Norwalk over years that the global health is so at the center of the discussion.
So obviously the people at the top recruit and are interested in physicians who've had global health training or have the mission. A lot of us got in before there was formal training or before even the term global health. We were all being citizens of the world before the global health concept had really taken hold. And so I would have to say that the steward of all this is Steve Winter. The head of pulmonary has been doing this on his own for many, many years. And every couple years, he will reach out and bring a couple physicians with him. But he was funding this and doing it independent of Norwalk Hospital. And over the time, it's built momentum. And there are many faculty who have had various experiences and have lived elsewhere and want to carry that on. So yes, we have a huge number of attendings who we crowd the rooms and we all have our own stories. We've all taken our own residents with us on trips, and we all have various types of funding. And yes, we have a lot of energy. We love global health.
Susan, you told me that there are 280 or 300 students that come through international office annually. I have 2 questions for you. One, who they are from that part of the world they come? And the second question is, what are the challenges of dealing with 280 basically participants that they have to come through a global health department?
Most of these students come from Europe. The biggest percentage of students come from Europe, especially the last 2 years. Previously, maybe 46% will come from America, but now I think you have the answer for that. Most of them come, 50% of them come from Europe, because Europe has a place in their curriculum where they allow students, actually they kind of force them to go and study abroad for a period of time. And they have a lot of funding for mobility. So we have students mostly from Maastricht, Karolinska Institute in Sweden, Bergen, and there are very many. But we still get students from US. And the biggest number of students from the US are now residents. I think because of funding now, they have global health trainings in curricula like UCSF, or recently Vermont, so Minnesota. So we have residents now coming in, representing America. The biggest challenge is for residents is registering them to practice, because you want them to be able to practice as doctors when they are visiting, as they are learning. So they do provide a service as they learn. So the biggest challenge is registering them to work in Uganda. And for students, the challenge is some of them adjusting to the culture, the health system, and then I know too much attitude. So, so that's the biggest challenge for those two.
Would you mind to comment about the students that we sent from University of Vermont?
Yes,
To,
yes.
Please.
So the students, I've told some of you, and I've told Professor Sadiq, we received students in Feb, and I think because Vermont has a big global health maybe program, they were well prepared to work in Uganda and live in Uganda. First of all, they didn't stay in the places where other students stay. They stayed with a family. So we have a Professor Roga hosting them, and they live in the community. So they live like Ugandans. They would travel every day from their house using a matatu, which is not anywhere in the US, but they would be in the office at 7:30. So for me, it was amazing. And I told them, why do you come early? They said, because we want to meet the jam. So they learned to live like Ugandans, which was very good. And so their complaining was not so much, and they were very, very adaptable to all the circumstances. They are willing to learn. They worked. They were very hardworking students. I think two of them were residents, yes, and they would work from 8 to 5. So they were, yes, very good ambassadors for Vermont.
One of them, in a matter of fact, was from family medicine, and lovely, mature, I would say, if you want to select somebody as the citizen of the world, you would give that young woman that title. And one was from pediatric department with the same quality, amazing, really, woman. So, and Susan was in touch with me and would say, really, there is so much difference between the resident and the students that we receive from University of Vermont and other parts of the world, because there are so many other elements into that, because this is phenomenal, really, a school, and attracts phenomenal, really, number of fantastic, really, students and faculty and residents. Professor Obua and also Professor Ziganshin, we know what we want to accomplish when we send students or residents to the South. What is the expectation of the South from the northward? What are you looking for a successful, really, partnership? What we should be doing to be qualified as a good partner in global health partnership? Yeah.
Thank you. I think that's a very fair question. The answer may not be very short, but I'll try to make it short. I think the key word in your presentation was bidirectional. That for long, we have understood one fact to be correct, that we understand health is global, but wealth is not global. Now, because wealth is not global, it's sometimes difficult to fulfill the bidirectional relationship that we would want to do. But that should not be a hindrance of what we in the South want. I think what we want in the South is we believe and understand there is no way we can say we want to be like Vermont, let's say Makerere University or Mbarara University, we want to be like Vermont, because I know it has taken centuries for Vermont to be what it is. At least when I was coming by the road, I saw it was 17 something, you know. 1776 or 1797, something like that. And I'm talking of a university like Bara University, 25 years old. And a country like Uganda, 50 years old. So the disparity is there. But I think what I would want to say on behalf of the South is true partnership, which is cemented through trust and understanding our differences. Because if we do not understand our differences, we fail to see how trust between the North and South can make this kind of partnership work. We want health for our people just like you want health for your people. We want to train our health professionals to be able to deliver the kind of services that you want to train your people here to deliver these services. So there is what we have, which you don't have. There is what you have, which we don't have. And the best example of what I would say works truly well for us in the South is not indoctrination, come to Vermont, learn in Vermont, then go back to Makerere or go back to Mbeera. Rather, learn a bit from Vermont, learn also from Makerere, and using what is the best practices in Vermont, go back, take that best practices to Uganda so that the people in Uganda can benefit from that. Just like you send the students and the residents from here to go, and it's not, Susan talked of attitude in some of the visitors we get, but I think that is a rarity. The majority of those who come actually truly want to learn how are things working in the South. And how can we come here and then make it better for the people in the South? So I would love to see a kind of relationship where our people in the South come to the North, see what you are doing here, and relate it to the way the situation back home is, and be able to deliver the kind of services that can be done. And I think through Dr. Majid, we have been able to achieve that very well through the Yale collaboration. And now I believe, from what Susan is telling me, that with the students and residents from Vermont who go in, who are slightly better prepared, because this, before we just came here, we had some briefing session with prospective students from Vermont who want to go down to the South. And I see the maturity in the way the students are prepared here. That means when they come down to the South, they are not only going to go and learn, they're actually coming to help, train, and share their experiences with our people from the South. So the South is praying for a true globalization in health. It may not be possible for the wealth part of it, but in health, I would pray that indeed we work together, that globalization in health. Can I have one more minute?
Certainly,
Okay.
certainly. Certainly.
The Ebola crisis in West Africa, I think, is a true example of what a concerted effort throughout the world can bring to end a real crisis, health crisis in the world. One would have said, it's their problem, let's leave it there. But you see, it took me how many hours to get to the US? Less than 24 hours. I woke up one morning in Uganda, and the next morning, I'm in the US. So if I was carrying the Ebola virus, within the 21 days that the incubation, I would already be spreading it here. So it's no longer their problem, it's our problem. And I think that's the way we will want to see it. So in health, in training, therefore, if we can work together and train a global doctor, that's what I want to see. Thank you.
Professor Zivachin, you have been in charge of international initiative in Kazan State Medical University for 20 plus years. What lessons you want to share with us?
Yes. The concept of global health in Russia is still a new concept for Russian medical education, higher medical education. And there are just a few medical schools in Russia who actually known to this idea. And I'm glad that Kazan University is one of those who actually have good experience. I would say that expectation from all these collaborations changed during the 20 years. Initially, of course, that was mostly to bring some professors from America to our university to learn, and probably to go there and just to open mind of our faculties that there is other possibilities to train others, doctors, as good trained as in Russia, because we've been always proud of Russian doctors by the history, and to change the ideas. And mostly, probably, we've been expected that our American partners will bring more things, even to our, even like books, like internet resources, like others, and to increase our possibilities to develop high medical education. But over the years, I would think that the attitude and expectations change, because we began to understand that actually we are very similar to each other in the matter of students, faculties, even in administrative, in people. And we learn to understand that actually the problems are also very similar. And we introduce a new concept now to our Global Health Office and international, that we have to think globally but act locally. And this, I think, it is the thing which we learned over the years, because we understand that, yes, as Professor Ovo said, that Ebola problem, it's not only Ebola's, not only African problems. They came in few hours, spread over the globe. So, and the same, the poor people, we do have also rural areas where poor people live, and they also need more medical care than probably people in cities, in the big cities like Kazan. So over this communication, over the collaboration years, the expectation and attitude of the students and the faculties to these collaborations change, and I would say improved.
I just want to tell you that really it doesn't matter you go to Uganda or you go to Russia. International office, they send somebody to airport to welcome you. They are going to take you to a home, very nice place. And also they would be basically assigning you to a clinical environment, hospital or outpatient. But international office of both of these two countries, they have supplementary curriculum for you. 3 times during the week, you have language classes. This is in addition of the language classes that you are going to receive during the dinner session, for instance. They are going to basically recruit some astute clinicians to teach you clinical exam and history taking and physical exam, particularly those who are the first year medical students. And they also teach you tropical medicine. There is very established really curriculum. But I have a tough question for the basically all of you, and that's safety issue that comes up very frequently. Uganda has both filoviruses, has Marburg as well as Ebola. Not only has just one Ebola, has 2 different species of Ebola, but more importantly, you have the most frequent outbreak of the filoviruses in Uganda, not in Congo. But good thing is that the CDC has phenomenal infrastructure that if the first case comes up, we'll never get to the second case because they have such amazing epidemiological surveillance system in place. But more so, you learned recently in basically Kenya, and then Al-Shabaab obviously is very active in Uganda as well. In Russia, obviously, is the Ukraine and American, all of those things. If a student asks me really these questions, or a mother or a father call me at the middle of the night, what shall really I respond to them? Professor OBrien.
Well, yes, thank you. I think the week before I came here, I had a visit from, we have some Peace Corps in Uganda, and they are in Mbarara University. One of them is an orthopedic surgeon. We have several nurses, so the question that the security officer he flew all the way from Dar es Salaam, from the U.S. Office to come because of the security concerns in Uganda. And of course, as you know, Uganda is helping to pacify Somalia, which America didn't do. But now that has its problem, because you are dealing with very radical people, and they are looking out for soft targets. And often it's not easy for you to predict where the soft targets, what is it that they're looking for. But we have learned from our previous mistakes when they bombed Kampala in 2010 during the soccer, it was the soccer finals in South Africa. And now we have had several alerts that are sent out if they are trying to come and attack Uganda. So the security system in Uganda, I wouldn't say it's 100% perfect, but it is quite good that we have been able to contain some of the threats that would otherwise have caused problem in Uganda. But also, your tribal adversary tells you that your safety is your primary concern. You are not expecting that you'll be walking at midnight and going to funny places because you expect somebody else to take care of that one. So we prepare you to be ready to take care of your own security. But also we assure you that, yes, we have tried to put in place measures to ensure that some of these events do not happen. We have secure places where we host the students. Susan has given an example of where they are living in the community. And we have found that actually you are safer in the homes than in a secluded group where they say the Americans are there. So you kind of, we have, and that's a discussion we have had recently with this security officer. I say, look, they were asking me, in Mbarara we have a flat where we keep, where we host visiting lecturers, foreign lecturers. So they were asking whether we could allocate the American Peace Corps that house. And I advised him, I said, no, that will be the wrong thing to do. Because we have visitors from Sweden, from the UK, from Cuba, from Japan, from all over. Hopefully we shall be having some from Kazan University to come. So this mix is good because there is security, there is safety in numbers, and not easily identifiable numbers. So I think that while we may not be able to predict the attacks by these groups, we try to put in place measures to ensure that you are safe. Susan will probably tell you We ensure that we pick up the students from the airport when they come. Those of you, I think we are still doing that? Yes. We pick them from the airport, deliver them where they're supposed to be staying. The following morning, they're given a brief, both a cultural and security brief, so that they are aware of what they need to do and avoid certain places. Just like in any city, let's say Kampala, there are places that you think twice going to, and then go in groups. So if you have to go out for a night, for example, you're advised to go in groups and take a local with you. And that way you know that some thing is being done. When we had the last Ebola break in Western Uganda, we had some visiting students. And I think we had some from Kazan. Yes. And those returned. I think they were. Absolutely. Yes, but we held a meeting with all the visiting students. I had one of the visiting lecturers from, she's a professor, Irish, who is teaching at the Infectious Disease Institute. So she gave them a talk about Ebola. The Ebola outbreak was some 300, 400 kilometers. As Majid said, we have had Ebola breaks, but they have remained local. They have never spread outside the area that they've occurred because of this good epidemiological system. So we briefed them on that and said, well, you're coming into global health. Imagine you are now a doctor in Bundibugyo where the Ebola outbreak took place. What would you do? And so in the end, we managed to persuade them, and they stayed. But we asked them whether they would want us to take them away to the eastern part of Uganda. And I think we took some of them to the eastern part of Uganda, a bit far away, again from there. So that's how we contained them. And I was on phone with the parents at 2 a.m., 4 a.m., and so on. But communication is good, and I think people want information. If you explain the situation to people, they understand. And I think this is what is important in this project.
It is also part of the pre-departure orientation. And more importantly, there is a protocol and there is a contract between Global Health Program and those that we send. And one is basically as soon as they get ready to Uganda or any other country, they have to register with American Embassy. And particularly, we are putting them really in Professor Lubuga's home to be completely far away from the campus, which is sometimes, in a matter of fact, the site of the demonstration against Museveni. So I read you, please, only 1 minute, because we have really,
about security measure, I would say that we are international university, and we have about 15% of our medical grad students, international students, coming from all over 52 different countries. So we have very good experience on getting international students.
Yes.
And of course, there are some rules you have to follow. Of course, it is up to you to make a sensitive movement around the city and not doing wrong things, as everywhere, as here or where, or Uganda. But if you follow specific rules, and if you are sensitive to the country, to the culture, to the people, you are safe, absolutely, no problem.
Thank you really very much. I know it's basically at 6 o'clock, and there is any question, because we can basically leave 5 minutes for any sort of question that you may have. But I would bet that all of the panelists are going to stay around, and if you have any question, they would be delighted really to answer. But if there is any question now from any of you. Yes, please.
I think one of the problems I see with knowledge is actually the platform where you get knowledge, right? Here in America, I can basically go on PubMed, up-to-date my different organizations, and I can pull information, publications that are yet to be published, things that can help me and have guidelines. I mean, I remember, like, if you go to Africa or to other poorer places in the world, actually having this information is not there for the students, right? So what does the University of Vermont do? You know, what's the University of Vermont doing to actually like level this playing field, flatten the world so that the students can actually like get access to, and I think the professors as well. Sometimes you talk to your colleagues from around the world, and some people will view journals from 5 years ago as if they were like very recent journals. Only the world has moved even before that article got published.
Yes.
So what are we doing?
I know by fact that one of the faculty of the OB Ecology, she has been extremely instrumental in matter of fact to bring the culture of evidence-based medicine to OB Ecology Department of Michael University, supplying them with computers, even funding them to have free access to Wi-Fi. And also, I would say in Zimbabwe, part of the MEPI grant, $25,000 a month has been crafted to bring Wi-Fi free of any charge to entirely medical school. And we did a study last year in Zimbabwe. The access to the web was not the problem. The problem was basically how to use really the evidence or the question that you have. And we are sending really a group soon in a matter of fact to Zimbabwe. And we are bringing one of the librarians, a very young, basically library employee to United States to learn all of the skills necessary to use the web basically efficiently and rightly in medical school. But obviously, there is no any question, and if you come tomorrow, please, those of you who are around between 3 and 5, we have, I think, really 8 or 10 posters that they have been between the last year and this year. They have been presented at a consortium of university in global health, the most basically scholarly platform for the global health experts. And I think really many of medical students last year and this year, they did have studies, and a couple of the studies in a matter of fact was about the access to the digital, basically medical information. But please come by tomorrow. There is the whole day. This is the second annual Global Health, basically, at University of Vermont. And tomorrow, basically, particularly, we have a grand round. And during that time, some of the medical students are going to basically read amazing pieces of the reflection that they wrote about their observations. And also, there is going to be exhibition of the 8 or 10 posters. And please welcome. And thank you really very much for the panelists. Thank you. I know that all of you, you deserve to go to the bed and sleep very well. Thank you very much.